introduce our first speaker. We are starting the first lecture with the tips and tricks in ESD by Dr. Alberto Murino. He's an international expert trained in St. Mark in UK and Erzimi Hospital in Belgium and Nagoya in Japan. He's a co-director of an international advanced endoscopy masterclass in London, honorary professor at UCL, focusing on EUS and endoscopic innovation. He got award-winning research on small bowel tumor detection via endoscopy. Thanks for being with us, Dr. Murino, and the floor is yours.
Thank you so much for your nice presentation. It's a pleasure to be here today. I have to congratulate on this conference, and I want to thank my friend Abdel for the invitation and all the hospital and the staff here. So today we're going to discuss about tips and tricks of ESD. So there are some basics: room setup, pocket creation method, site, traction, suction, prevention of bleeding management. So the basics, and this is a slide that my dear friend and colleague gave me. It's very important when we practice endoscopy or ESD in particular to have a fine-tipped control. So many times we go to some training and of course we see endoscopies that handle the scope with two ends and the tip of the scope goes everywhere. But fine-tip control is all about small movement, no pressure, and because when you perform ESD, you have to be very delicate. And these are the movements that we teach to our fellows, and we show everyone that is trained with us, both in our hospital and in any course we attend. What about room setup and tools? So first of all, before the procedure, it's important to discuss with the patient, because patient needs to be aware of which procedure we're going to do, what are the benefits, what are the risks. And I can tell you that now that in our hospital we have an endoscopy MDT established, this makes things much easier, because the patient knows that they're coming for an ESD, it's a long procedure, there are some risks, and if there is any complication, they are ready for that, because that has been discussed. So very important. Well, of course, we need to know patient medical history very well and the therapy, and have a good consent. And then once we have the lesion, we have to assess the lesion and strategically plan which type of resection we're going to perform. In our center is site ESD only, and also the time management. So we have to have everything in our room, and also we need to have a good pedal configuration, because what we do in our unit is, because we do everything under saline, we have two pump controller, one for the water jet and one for the knife jet. Then here is the endoscopist, and here is the RB pedal. So this is my configuration. Ed has a slightly different configuration, but it's important that then we can see the RB machine, the screens in front of us, and the two nurses, one assist us and one close to the patient. Of course, we need to use the right cup, and this is very much depending on every preference, but there is the conventional hasty food, the short hasty food, and then there is the large cup. We use the short hasty food. And then this is our knives from my island where I'm born in Sardinia. We need to know our knives. Every knife is different, but everyone has his own preference. And it very much depends on the first knife you have been trained. That's we use flash knife and the hybrid knife. Of course, there are several different types of knife, and I would recommend to use 1.5 millimeter knife, because it's the safest and it can give you a very exact cut. While when you use the 2 millimeter, 2.5, you cut very far away and you can end up with some injuries. So pocket creation method is it was introduced by Professor Hironori Yamamoto as an alternative to conventional ESD. So what is pocket creation method? Essentially, if this is the lesion, we inject the lesion and then we make a little incision and then we create a pocket underneath the lesion. Then we open the pocket, following first the anti-gravity site and then the gravity site, and then we remove the lesion. It's, you know, now well established worldwide, and it's very important because this type of ESD has great advantages. First of all, the scope is stabilized underneath the lesion, and you can also clearly see the plane that you have to see, and you maintain the fluids underneath the lesion within the pocket. So the other thing is that you see very well the muscle layer, and this will guide you throughout your resection. And not only that, but when the patient you know, breathe, so you have all this breathing movement, and you sometimes get like sick because of all this movement. Once you are in the pocket, these movements are actually zero. You don't see the movement again because your endoscope moves within the lesion. So why pocket creation method is also very, very useful, because in these scenarios, like in retroflexion in the rectum, what is important is to aspirate and suck all the air, and then create a pocket underneath the lesion and keeping aspirating the air so that you have a good plane. And the same is when you have some lesion on a fold. What you need to do is try to aspirate the air, minimize the gas inside the patient so that you kind of flatten the colonic wall. The same for the flexures. And in some cases, there are some more difficult scenarios where you have a polyp which is growing within, let's say, a fold, but you are not entirely sure if this is muscle layering or if it's fibrosis. Because in this very large polyp, what happens is you have at some point this type of situation where you can see here the submucosal layer, and here it becomes a bit more difficult. You lose the submucosal because the submucosal little by little disappear, and instead of the submucosa you have this thick fibrosis. So it's always a bit challenging to understand if this is really fibrosis or if it is early invasion. What we found is that these vessels here, which are irregular and converging towards the fibrotic area, are sometimes predictors of an early invasive cancer. Despite that, what we suggest, because that's not an 100% sign, we suggest to carry on with the resection until there is a point whether you will see again the submucosal layer, or until there is a point where the fibrosis became absolutely impossible to manage, and then you stop, because this increases the risk of perforation and bleeding. Going forward, if I can, we have in our unit adopted a new strategy that we have introduced in 2017 with my dear colleague Despot, who is sitting in the first row. And essentially, we initially were working as everyone with CO2 and a bit of water to wash the mucosa, to wash the lumen. But it was very difficult because we were using, especially in the rectum or in the left side, a gastroscope. And sucking the liquid with a gastroscope when you had a knife inside was very difficult and time-consuming. So at some point we started using water, but we realized that water wasn't really work perfectly. Why? Because water, so we expected the same result of, in terms of cutting, incision, and coagulation with water. But actually, this was more difficult. Why? Because this has a less conductivity. And this is why, wherever we go, we insist on the use of site. Site, because of its intrinsic properties, has more conductivity because of the Cl, which is then go closer to the resection site and propagate the energy of the cutting. And therefore, we realize also that site is much better in terms of time, in terms of safety, in terms of effectiveness. But also, as you can see in these videos, sight gives you a much better visualization of the plane. So we start almost all our procedure under sight, even when we start with incision. So I'll go a bit further. As you can see here, you can see very well the muscle layer, the submucosal layer, the lesion. You are very precise, and even during the bleeding, you can actually identify the bleeding point very easily. So sight, it's very useful, and if you don't believe me, I'll give you another example. Here is the pocket. We're using sight, Olympus scope with ear focus, and you can see every little detail in the pocket. And this gives you a lot of confidence, and is also very safe for the patient. Going forward, another important characteristic of sight is the buoyancy effect. In fact, one of the main problems there was with CO2, it was the gravity. How many times have you heard about, oh, you have to bring the patient on his left or on his right, have the gravity on your side, and then when you are going forward with your procedure, you have to turn the patient on this way, so the gravity is on that way, or you have to open the pocket on the anti-gravity side, and then the gravity side, and you get confused. But with saline, this problem with gravity is basically zero, is erased, is cancelled, because there is no gravity anymore. The gravity is gone. And what you have is what, and this is, again, adds a nice picture, what you have underneath the sea. So you have everything floating, while when it is on CO2, it doesn't float anymore, and that became a problem also for a traction point of view. So here, for example, you can see how nicely the lesion floats, even if it's injected, and you can trim it safely. You can go underneath the lesion absolutely more easily than when using CO2. So this is another important thing of sight. And additionally, comfort, because one of the main problems that we have with ESD, with prolonged ESD, is about sedation. So in UK, in our country where we work, we have mostly midazolam and fentanyl. We don't have the luxury of having an anesthetist in our room for the majority of time. So what we realize is that because we use saline, and we also use an aspiration tube that I will show you in a second, there is no dilatation of the bowel, there is no stretching on the mesentery, and the patient is comfortable. But I'll tell you what, even if you have a perforation, the patient remains comfortable, because the CO2 that usually get into the abdominal cavity with saline is minimized. So this is an overview of an abstract that we have recently submitted and has been accepted as oral at the ESG days. So out of 177 patients, median ASE score was 2, so quite comorbid. 40 millimeter medium size diameter of the lesion, a median resection size 2 hours. We used 5 milligrams of midazolam and under 37 milligrams on fentanyl. So that's it. That's what the patient needs in our unit. And this with CO2 is essentially impossible. We only had one complication of an 8-year-old patient with asbestosis, which experienced moderate respiratory failure, which was resolved in the recovery area and did not require ITU admission. Another useful thing that we have added recently to our strategy is that when we finish the pocket, what we do to speed up the process of the ESD is we add the traction to our distal margin, and then we, of course, with another clip it on the distal part of the contralateral wall. And this exposes the lateral side of the pocket, and it's very quick to open the pocket in this way. So one of historically the difficulties of the pocket where it slow down the procedure is to open the pocket, and we found that this made the procedure much, much quicker. So I would also recommend to do this, and I would recommend when you clip your rubber band, clip it distally, non proximally, because distally you always clip, you always maintain the traction. While if you clip it proximally, you lose the traction as you open the pocket. And finally, this is another additional tools that we have added in our daily routine. It was introduced by Professor Hinorori Yamamoto Hayashi from Jichi Medical University, and this is called, as we renamed, the Aesculapius tube. So it's essentially an NJ tube that we wrap up around our endoscope, and it goes with continuous aspiration, low aspiration. Or the other thing you can do if you are working in the rectum is you can use a Foley catheter, as you can see here. That's the Foley on your right, which is inflate. And you will see the results of this very quickly. So here you have now the Foley is on, so there is aspiration, and you will see how the mucosa will deflate. Okay, we're not using the scope to deflate the mucosa, it's the catheter. And I'll show you another part, so that's one of our ESD. Now, the water jet is on, the CO2 is off, and the Foley is on. So there is aspiration, but you can see that the lumen is very small. There is only a small amount of saline in here. And as we remove the Foley, and I will show you in a second, you will see that this, now the Foley is off, and you will see that the lumen is expanded. So this is very effective, and this not only reduces time because you don't have to suck anymore, not only reduce pain on the patient and so reduce the level of consciousness, but is also make your procedure much easier. Those are our setting. We have a slight difference in our setting, but you know, this doesn't make big difference at the end of the day. So settings, as I always say, are very much personal and depending on the knife and on the situation that you find yourself in. Bleeding management, and I'm going towards the finishing my talk. So if this is vessel, I would recommend to cut the vessel after coagulation above the muscle layer, quite above the muscle layer, so that if there is then bleeding, you don't have to deal with a vessel coming out from the muscle layer, which is always a difficult situation. So you have space. In this case, as you can see here, if these vessels start bleeding, you don't have space anymore, and you might end up with a muscle injury. And this is how we do in our unit. As you can see, submucosal space, vessel, muscular mucosa, and the lesion. And once the vessel is well defined, we isolate the vessel from one side and from the other side, and then with a knife, we coagulate and then cut it through. But also, there are a bit more difficult scenarios where we have to use the coag rasper. It's nowadays very unusual to use the coag rasper. One of these was, there was a bleeding point here, and very easily with a knife it can be absolutely removed. And finally, we can also use the Purostat, which is a special gel that stops the bleeding. Purostat, we use it both during the procedure, especially if we have some bleeding that is not manageable with a knife or with a coag rasper. You just inject it and leave it there for a few minutes. And as you can see here, this was a bleeding close to the muscle layer. I was afraid of a perforation using the coag rasper, and the knife wasn't working, so I left some Purostat, as you can see here, and after a couple of minutes, as I will show you in this video, the bleeding completely stopped. That's a few minutes afterwards, the bleeding had stopped. So that's very effective. And don't forget ergonomics, because we are endoscopists and we have to work for decades. So that's important for your health and for patient, and for looking after your patient. Thank you so much. That's my friend Ed, my team at the Royal Free. And we wish you to invite all in our conference, which will be from the 11th and 13th to June in Malta for the 7th edition of our International Advanced Endoscopy